Thank you so much, everybody. Welcome to today's webinar, Preparing for a Regulatory Survey, Tips and Best Practices from a Former Surveyor. So thanks so much for joining us. I'm Sharon Beckwith. I'm the President of Peer Review and Clinical Quality Consulting Solutions at the Hardenbergh Group, and I'll be the moderator for today's program. Today's webinar is being sponsored and hosted by the Hardenbergh Group and MD Review, a Hardenbergh company. So before we begin today's program, just a few little details. All attendees' microphones have been muted and chat has actually been disabled. So if you'd like to ask questions throughout the program, please go ahead and use the Q&A icon located on the navigation bar. Typically it's at the bottom of your screen. Sometimes it floats to the top, just depending on your setup. Go ahead and just type your question. So as time permits, at the end of the program, I'll go ahead and read the questions and ask our presenters to respond. Your NAMSS-approved CE certificate will be emailed to you within about 48 hours directly from the Hardenbergh Group. It'll come in your thank you for attending follow-up email. Also included in the email will be slides from today's presentation and a link to a short survey. So we would really appreciate if you would take the time to fill out that survey and give us your feedback. So now it is my pleasure to introduce today's presenters, Dr. Laurel McCourt and Sara Cameron. Dr. McCourt is a former board-certified family medicine physician. She began her career as a Joint Commission surveyor in 2004 and served as a team leader for both deemed and non-deemed hospital systems, and also consulted with the Joint Commission at a broad range of organizations from rural community hospitals to large academic centers. During her career, she was active in the Speakers Bureau, and her presentations included hospital and ambulatory accreditation standards and the survey process. Dr. McCourt is currently an independent healthcare consultant with an emphasis on medical staff standards and compliance. We're so excited to have you here with us today, Dr. McCourt. Thank you so much.
Thank you, Sharon.
Sara Cameron is a director of professional services at the Hardenbergh Group. She has over 22 years of experience in healthcare administration and medical staff services. She's held roles in critical access, academic, and tertiary centers, and brings her vast experience and accomplishments serving large health systems to support clients by imparting best practices to their medical staff in the areas of credentialing, privileging, peer review, professionalism, and performance improvement. So excited to have both of you here today. I think we've got an amazing content for everybody. So today, just kind of looking at our topics or looking at our learning objectives, we really want to understand the surveyor's expectations of a regulatory visit, identify useful tips to help prepare for that regulatory visit. Sometimes it can be a little nerve-wracking, and learn how to effectively prepare the medical staff for the survey. So again, we've got two speakers here today with such a wealth of information. And really, this webinar was designed for you, the participants, the attendees, those of you that are out there listening. We actually had questions that were submitted in advance of today's webinar. We sincerely appreciate everyone that submitted a question to us. We had some amazingly great questions. So we're actually going to answer those throughout the content today and today's presentation. And we also have some at the end as well. So I'm going to go ahead and turn it over to Dr. McCourt because we have lots to cover today.
Okay. Well, good morning or good afternoon, everyone. I am absolutely delighted to be back on a webinar. I'd love to be able to see all of your faces, but I really appreciate your time in attending this. As you all know, I retired from the Joint Commission in December of last year and missed out on some of those medical staff presentations that I just absolutely loved giving year in and year out. So I am sure you found a great replacement for me this year. And I was thrilled when the Hardenbergh Group contacted me and asked me to be a part of this presentation specifically. And as what any good physician would do when they've been out of practice for 10 months. They would find an extremely excellent MSP to help them out. And fortunately, I have Sara helping me out in this presentation, and she really has been great to work with. And I think between the two of us, we will get a lot of information out to you and hopefully answer all the questions that came in prior to the presentation, and some that we actually came up with as we went through our mutual experiences throughout our careers. So with that being said, we'll get started. My part of this presentation is really to go over the online resources of your accreditors. And we're going to focus on CMS, the Joint Commission, and DNV. Those are the top 3 accreditors. There are other accreditors. So if you're accredited by someone else, CMS would include, of course, your state, if you use your state for accreditation. And there are naturally a lot more slides about the Joint Commission, because that's where all of my familiarity is. I will say that all but one of these resources is publicly available. So I want to make that clear, that, and I'll tell you when we get to that one, how people who are part of a Joint Commission accredited organization can access that resource. But everything else is publicly available on the respective website of the accreditor. Okay, so I'm going to start with CMS. As many of you, if not all of you, are aware, the condition of participation upon which all standards for all accreditors are based is 482.22. That comes from CMS. Your CMS regulations are publicly available. All you have to do is type in CMS condition of participation 482.22 into your search engine, and you will come up with the CMS documentation. CMS is very clear about their documentation. They state the statement, then they state the interpretive guidelines, and what their expectations are of organizations, and then they talk about their survey procedures. So it's important that you start off familiarizing yourself, with this condition of participation, and so you know where the very baseline is for your standards. As I said, they're very specific about their survey procedures, so there's no surprises. And many times CMS might show up at your organization when they are investigating a complaint or a concern that has been brought to their attention. And you may get a call from the quality manager saying, CMS is here about the surgical fire we had 3 months ago, and they are investigating that. So pull the files on these providers who were part of the team that experienced the surgical fire. So you will know exactly what to expect if you just look at these survey procedures. This is what they're going to be looking for, and you won't have any surprises from them. It's very straightforward what CMS is looking for when they are on site. Now, CMS, unlike the Joint Commission or any other accreditor, when they're on site, they stay until they're done. So if it takes them a day and they're done, fine. If it takes them a week, whatever it is, CMS will stay until they are done investigating. Or if they come in for a survey, they will stay until they're finished with the survey. Next slide. So now we come to what is obviously near and dear to my heart, and that is the Joint Commission. And I'm going to start off talking about e-alerts, and Sara was very helpful to include the links for all of these items. As I said, this is publicly available on the Joint Commission website. E-alerts are very valuable because the Joint Commission might put out an e-alert, and it might say, we're going to put into an effect, or we're going to put a new standard into the book, and we want it out there for field review, because they want to know what the field, i.e. all of you, or your medical staff or your quality folks think about this standard before it goes in the book. So this also tells you when the new manuals are available, et cetera. So much of this is product and presentation alerts, but it also has some interesting e-alerts. And when you get e-alerts, they're very short. They may link to a link, but you know, you can always delete it. If it has nothing to do with what you're doing, delete it. But if it is something that has something to do with medical staff, it's good to bring to the attention of your medical staff leadership. Next slide. Okay, now there are really important resources on the Joint Commission website, and my goal here today is to show you how to get to those resources. I think one of the most difficult things I had when I was working for the Joint Commission was they would put out 10, 12 publications a month, and it'd be like, how do I have time to read all these? What should I read? What do I need to know? So the main thing that I would encourage all of you to take the time to look at least somebody in your office monthly, if not, this one probably can be quarterly, but you need to go to the main page of the Joint Commission website, go to your standards window, and I know you're all sitting there in front of your computer right now, go to the standards window, and then click on the pre-publication standards. This is where you would have seen first that the standard was changing to a 3-year reappointment cycle, for example, for medical staff. And it is important that these pre-publication standards are really your heads up, that these are standards that are going to be added to the Joint Commission manual. May not be in the manual yet, but it will, if you go to that standard, it'll tell you when it will be in effect. Sometimes the Joint Commission makes standards immediately effective, and sometimes they'll say they won't be effective till the next January, or if it's prior to July, it might take effect in July. One of the most important things, and I really want to emphasize this to all of you, is going back to that homepage of the Joint Commission and going to the standards window and then the standards FAQ. Now, one of the things, and I should have mentioned this early on when we were on the slide with the 3 creditors we're going to be talking about, the Joint Commission's resources, all of these, like I said, with the exception of one slide towards the end, are publicly available. So even if you use an accreditor other than the Joint Commission, this information is available. And having given presentations with individuals from DNV and other accreditors, when we would talk either prior to or during the panels, pretty much all of us said the same thing. We're all looking for the same thing, because we all have to answer to CMS when we go after our ability to be one of their deeming authorities or one of their accreditors. So it is not unusual for all of us to say, oh yes, we all have OPPE. We might not all call it that, but we all have it. So with regard to these FAQs, the important thing here is that these really offer clarity on the standards. And we're going to spend time later in this presentation as we answer some questions showing you just how important these are. When you read, for example, the standard on OPPE, it is very vague, very non-specific, but you read the FAQ and you get so much more information. And I will say, ever since 2020 and during the pandemic, the Joint Commission has worked very hard to update these regularly. So I would highly encourage you to have someone in your office, or if you happen to be one of those one-person offices, I would check these FAQs at least quarterly, if not monthly, to make sure nothing has been updated. Because if the survey team shows up and they ask for a certain thing and they're reviewing it, and you're looking at it and you're saying, well, how would I have known that it's not in the standard? Well, it's in the FAQ. And the expectation is that you're familiar with those.
One of the comments that I made to Lori that I think will resonate with a lot of the MSPs on the call is that we're used to websites having FAQs that are, commonly asked questions. Here's some common answers, but the Joint Commission FAQs really are a dug into the details of how to accomplish those standards. So try to think of the Joint Commission FAQs as even bigger than the standard FAQs that we see on all kinds of different websites.
Thanks, Sarah. Okay, so the next thing, and actually I was kind of surprised this is publicly available on the Joint Commission website. I thought it was only available to Joint Commission accredited organizations, but it's not. I found all of these slides and screenshots on the Joint Commission website, and I no longer have that special access I had when I was a Joint Commission employee. So I will tell you the Joint Commission Survey Activity Guide is publicly available, and this is one of the most valuable resources for all of you. And as I go through this, I'm sure Sarah's going to jump in, because there were things that she was like, I really did not know that this was available to look at for MSPs. So this is very detailed information on how the survey will go, what the expectations is for every session, not just the medical staff session. It really outlines all the critical areas of focus, and it is updated. I think on the next slide I have it.
Yep.
But it is updated twice a year. So every one of you should be checking this in June and December. So we're coming up on December now. So you should be looking for the survey activity guide for 2024. It'll probably be out sometime mid-December. And it will say what's new for the hospital's process. This one came out in June for effective July 1st. And if you look, the medical staff bylaws review guide was updated. I'm going to talk about that wonderful document in a minute, but it was updated to reflect the changes in the fact that you can extend the reappointment cycle from 2 years to 3 years. So we're going to talk about this in a minute, but I do want to show you a copy of the table of contents for the survey activity guide. This table of contents, as you see, that's highlighted, the medical staff credentialing and privileging session. That is everything you ever wanted to know that the Joint Commission is going to look for during your credentialing and privileging session. That's how it should go. And Sarah's going to get into more of the meat of this, of who should be there, etc. But this will really help you. And if it changes, it will be evident and updated. Like I said in the very beginning, it says what's new. There's nothing new for medical staff. Go right to your table of contents. The second thing that is available is an addendum in the survey activity guide called the Medical Staff Related Standards Compliance Evaluation Guide. Okay, next slide. And these 4 documents, I will tell you, the Joint Commission, if they go through the trouble to A, create the documents, and then B, put them in the survey activity guide, the expectation is A, that you'll use them, and B, that the surveyors will use them. So these 4 guides, there's the Medical Staff Bylaws Review Guide, the Medical Staff and Related Standards Compliance Evaluation Guide, the Professional Graduate Medical Education Program Guide, in case you are one of those organizations that has a residency programs, even if you just have residents that float through every once in a while, but you aren't the home place of the residency program. Still important to look at this and see what applies to you. And then the credentials file review tool. Okay, next slide. So the survey activity guide, one of the things that's in there, as I said, was the bylaws review guide. Now, any of you who may have been around as long as I have been, remember when CMS updated what had to be in the bylaws. And when they updated what had to be in the bylaws and they revised MS 010101, the Joint Commission said, okay, we're going to revise our standards to reflect what's in that document from CMS. Well, one of the things that I always asked, and Sara shivered when I said I asked this, but when I was a surveyor, and even when I was a consultant, one of the first things I did, because as you know, the bylaws are a required document that you have to have ready at all times. But I would always ask, if it wasn't already done, I would ask the medical staff professional to tab a copy of the bylaws with everything that's required to be in the bylaws. Now, that's not the rules and regs. So if lo and behold, you do the bylaws review guide and you're saying, well, wait a minute, this isn't in the bylaws, this is in the rules and regulations. How did it get there? You need to get with your medical staff leadership and figure it out. Because if it's required by this tool to be in the bylaws, then you should have it tabbed in your bylaws. And if you always keep a tabbed copy ready in case a surveyor walks in the door, then you'll know it's all in the bylaws. It didn't sneak out into a policy or out into the rules and regs, because lo and behold, the docs decided they really didn't want that H&P requirement in EP 16 to be in the bylaws anymore. They want it out in the rules and regs. So would highly recommend you tab your bylaws and keep that tab copy handy at all times. And remember, not everything that has to be in the bylaws is necessarily in the medical staff chapter. And this particular document will even touch on the things that aren't in the medical staff chapter that still have to be in the bylaws.
I just want to piggyback onto Lori's comment when we were developing this presentation, and she said, if I got a printed copy of the bylaws, which as an MSP, you've all been asked by your quality department to provide that so it's ready when the surveyor walks in. She said, I would send it back to that MSP and ask them to tab it. And I was like, ooh, what?
Yeah.
Like, that would overwhelm me on the day of a survey. So we talked about that, and she said it's an easier way for that surveyor to get through all of the elements and assure they're there. And I'm thinking with my MSP brain, man, if that's something surveyors love and I can provide it up front to them, how much better is it going to go when they come in for my document review? Because they've already figured out that I'm knowledgeable about all of the EPs that should be in my bylaws. And let's face it, as an MSP, you have one of these in your office. You have a set of bylaws that you've tabbed with the EPs, you've tabbed with relevant sections that we have to refer to often when a physician at MEC asks us, what does the bylaws say? So we have our own tabbed copy, but how beneficial to have a tabbed copy for you to hand over to that surveyor. And that's just going to set you up for such a good rapport with that surveyor when you sit down to review those files. So this was a tip that was mind-blowing to me, and I've been in the industry for a long time. So I think that you guys go back after this, and if you do one thing and one thing only, tab those bylaws, because I think it's going to really change that atmosphere of your surveys.
Right. This is another document out of that survey activity guide. And when Sara and I were looking through and looking at this document, things we wanted to pull out, we wanted to show you that this is what, again, the surveyors, one of the charges that CMS gives all accreditors is they want a consistent survey process. The Joint Commission has been working towards consistency for a long time, and there's a question about this later on in this presentation, so I'm not going to delve into it too much right now. But one of the things that the Joint Commission is doing, and if you look at that survey activity guide table of contents, they have their life safety code checklist, they have their kitchen tracer checklist, they have all of these checklists, and the reason is they want the surveyors to be more consistent. But this really does illustrate exactly what the Joint Commission surveyor is going to be looking for, and in each element of performance. So it's broken down to each element of performance, and this is what they're going to use when they're going through the files, and they'll be checking yes or no based on their findings when they go through the files. So I really encourage you to take a look at this. And I think there's another slide that illustrates even more of this, because as you can see, if you look to the right of the slide where the standards are listed, you can see these are from the provision of care chapter. These are from the emergency management chapter. You know, little did you know that the MEC has to approve the dietary manual for the hospital. That's part of the provision of care chapter. And believe me, I don't think I've been on a survey or talked to a surveyor recently that doesn't still look for this dietary manual. And so really, it's one of those little things that can kind of slip through the cracks, but unfortunately it's typically the medical staff professional who's sitting next to that surveyor when they're asking the question, and you'll be like, I
love
even
this
think of
screenshot.
things.
And I think that this may resonate with some of those MSPs on the call, but how many times have you had a surveyor ask for, show me where the MEC approved that dietary manual, or show me where the MEC approves the nuclear medicine medical director has signed off? And you go, oh, I'm going to have to call radiology. I know we did that at MEC, but the signed evidence of it is in radiology. Having this checklist of all the various things that can apply to a medical staff is just gold for an MSP, because these are some of the things we don't think about because they're outside of privileging and credentialing, and they're outside of the PPE process, but they are often things we get called to the mat and we have to say to the surveyor, I'll have to find that. Or you look across the table at the quality scribe and look at them like, can you call radiology and see if you can grab that? So knowing some of those things that they may look for is just so helpful.
Okay. All right. Now this, remember I told you there's one place that only individuals that have an email address from a Joint Commission accredited organization can get to. Well, this is the slide. Joint Commission Connect is a separate part of the Joint Commission's website that is only available to accredited organizations. And typically there's one or two people in most organizations that have access to this information. However, there are certain things you can access if you have a Joint Commission accredited hospital email address, and you can access what's called guest access. You have to sign up for it. And when you do sign up for it, the quality director or quality manager will get an email saying, hey, guess what? Sarah just signed up for guest access. Well, probably it's a good idea to let that person know ahead of time so that they aren't surprised. But honestly, what I always told quality directors when I was a consultant and as a surveyor, you need all the help you can get. So if someone wants to sign up for guest access so they can access these standards, now I'm talking the standards book, that is the one thing that is not publicly available on the Joint Commission website. You have to purchase that. So if they can access the standards and I don't have to give them the medical staff chapter, hey, great. I am happy that they have guest access. So, but you have to have that rapport with your quality director. And if you've heard me speak before, I have said this oftentimes, if not all the time, that if you're not joined at the hip with quality, you'll never get through OPPE. So I am hoping that all of you have that kind of relationship with your quality directors by this point in healthcare's career, because it's just invaluable to you and them to have you be available to know who's been privileged to do what when they're asking about quality issues or quality data. Okay, and finally, I'm showing this slide. This is from the DNV website. Again, this is their frequently asked questions. I am sure your DNV accreditors, as with Joint Commission, or I wouldn't say necessarily, it's a little harder to work with the federal government on things, but when you're talking to your accreditors, they want you to be accredited. They want you to be available for your community. And I know sometimes it doesn't feel like that, but that is the goal. So I would highly encourage you, if you have questions, go to your quality director, say, gee, okay, I have this information. I think I know what the Joint Commission would have wanted, but gee, now we've changed accreditors and now we're DNV. I'm not sure if they're going to want the same thing. Is there a way I can contact somebody, ask some questions before they necessarily come in for surveys? So it is slightly different processes, even though we're all getting hopefully to the same endpoint, and that's safe patient care. I always say, put the patient in the middle of the table, and then imagine that they're your mother, father, child, etc. What would you want to happen to them? And I once had a CEO of a hospital say to me, His idea of healthcare was it's a Friday night at 9 o'clock and his father gets admitted to the emergency room with a heart attack. And he feels no need to call and say, that's my dad, take good care of him. And he said, that's where ideal healthcare should be. It shouldn't matter who that person is that's laying on the table. We unfortunately all know that isn't necessarily true yet, but the goal is that we're all there. And that is honestly what your accreditors want from you. And that's why they're so stringent and sometimes seemingly overzealous, but their job is to make sure when they leave, and I can tell you as a former surveyor, my nightmares were filled with, oh my gosh, I left that organization and a sentinel event happened after I left. And I could have stopped it had I just found that glitch, that problem in their processes that would have prevented that. So believe me when I tell you, all accreditors used to be healthcare workers, and they are all as dedicated as all of you to trying to make sure you have safe patient care. Okay.
I'm going to take it over for a little bit, let you take a drink of your coffee or your tea. So general readiness, one of the things that we as MSPs have to think about and have in our mindset is what's it going to look like? We know when the accreditor comes in, we get a schedule usually within the first couple of hours, and we know, okay, my session is on day 3 at noon. Got it. Is the room comfortable? That's something that, you know, we want to make that surveyor's process as easy and seamless as possible. Having those tabbed bylaws, but also, is there enough space in the room? Remember that surveyor is going to come in with sort of that entourage that they travel with. They've got a quality scribe, they've got people. Are you doing it in your little tiny medical staff office, in your office, or have you arranged a conference space? Do you have some water available? Is there good internet access? You know, some places in the hospital do not have great internet access. Let's not be trying to pull up our credentialing database in a room that doesn't have that good access. So just some generalities to think about there. I love this one. Who should attend? This is so important. How many times did I, as an MSP, end up sitting in the room with the surveyor and all the quality team, and it was just me going through files? Really be thoughtful and prepared, and make your medical staff prepared and aware. We're going to talk in another slide about who should actually be at that table in a little more detail, but you want your medical staff leaders who are available there. Now, I will say sometimes I would have to kind of kick my CMO under the table and be like, stop saying that. That's not what we do. Not because he was giving away too much, but he would try to speak to a process that wasn't actually accurate to our processes. And I'd be like, that's not correct, but I didn't want to call him out. So be thoughtful about who you're going to have there. Have them prepped, have them ready, show them that tabbed bylaws, show them the audit tools that we use to go through files, so that when the surveyor is asking those questions, that CMO, that president, is empowered to answer those questions and answer them correctly and not get kicked under the table. So that's just a really important element that I think it's part of our responsibility as MSPs to educate those CMOs about those intricacies of the manual that relates to us. And again, don't get stuck sitting there on your own without any physicians present.
Yes, it is not, I'll just piggyback on this. It is not a good look for the surveyor to feel, as I did on more than one occasion, on day 3 of a 5-day survey, and wonder if they actually had doctors at the hospital, because I hadn't met one yet. So, you know, we know that doctors tend to scatter, and all of a sudden they discharge their patients so they don't have to be in the hospital because they know the Joint Commission's there. Yeah, it's some ways it's kind of scary sometimes, but yeah, it is important. Yeah, the more that they can be comfortable, and I don't know if this was where I was going to throw this in, but if your organization happens to hire consultants, and I heard this as a consultant many times when I hadn't met any of the doctors, and they're like, well, they'll be there for the real thing. Well, let me tell you, having done the real thing for 10 years, they don't know what to do during the real thing if they don't practice.
Those physicians do scatter. I mean, yes. I know as an MSP, I'm sure other MSPs can speak to it. When they hear Joint Commission is there, Oh, those ER doctors are like, why did it have to be during my shift? Why? I mean, it really is. It's just as stressful for them as it is for us who have to show up and show the files. But the more we prepare them, the less stressed they will be when they do show up. If we prepare them and say, these are the things they'll ask for, these are the things we'll present, these are the processes we will speak to, wow, they're going to rock that survey, and the surveyor will be impressed that you had that physician staff there. And we're going to talk about kind of scheduling that here in a minute. We had a question come in. Do you recommend having the surveyor attend the credentials, MEC, and the board meetings if those occur during the time that the survey is taking place? And surveyor says,
no. Surveyors have a very strict schedule. They have a lot to accomplish. And I know it seems like for you guys, it seems an eternity, but to them, it goes by in a heartbeat, and they have very limited time in the facility. So it's not necessary they attend. I did on occasion get the request, will you at least go to the MEC meeting and introduce yourself and answer any questions? And I would do that. Usually took about 10 minutes. But honestly, they're not going to accomplish what they need to accomplish at an MEC or a board meeting or a credentials meeting if the surveyor is sitting there. So it's important that I wouldn't even tell them if they happen to find out about it because one of your well-meaning medical staff says, hey, why don't you come to the MEC meeting tonight? You can let the surveyor handle it. They're trained to handle those kind of questions tactfully. And like I said, I would show up maybe for 10 minutes and just answer any questions, or because they heard by the grapevine, oh, we got scored in this, and it's because the anesthesiologists weren't doing their reviews or whatever. And so then they, of course, want to ask the surveyor. So yeah, it's fine. It's fine if they ask, but you don't have to tell them about it.
Yeah. So, okay, we're prepared. We've done some work. We're ready for them to show up. They're here. What is the first thing we need to do? We need to have a great relationship with that quality team. There's going to be an incident command type station that is sort of organizing all of the Joint Commission activities. They know where each of the surveyors are. They know the schedule. They know which scribe is with which person. And we as MSPs need to be vigilant in asking, what area are they in? Okay, they're in the ICU. Look at a schedule. Who's on in the ICU? Which physicians are currently the intensivists on schedule? Which floors did they visit? Which patients did they see? Who's the attending hospitalist? Okay, they're in the ED. Which ED providers are on today? And we're grabbing those files. We're figuring it out before we ever get a list. I know you're thinking to yourself, oh my gosh, we'd have so many extra files to audit if we pull everything from the tracer. But I'm going to give you some tips and tricks about being ready with those files, but this is to your advantage to be aware before that surveyor ever gives you a list. Where are they at? Whose files might they run into? And let's not just focus on the physicians. Our hospitalists, our ED, all of our areas also have nurse practitioners and PAs. And you bet your bottom that surveyor is going to ask for some APP files. They want to see that our processes for those APPs is just as consistent as our processes for the physicians. I know you had something you wanted to talk about the scribes as well, Lori.
Right. Yeah. I mean, ideally, if you could get with the scribe, I know it's going to be some tracking down, or maybe you're just like have one of your staff, if you have more than just you, posted in that incident command, and you're listening. Okay, we saw Dr. McCourt's patient. We see this nurse practitioner was with her. This PA was with her. And maybe just gleaning it from that, but trying to get those names. But don't worry, you're not going to have to go through 40 files. You don't have time to go through 40 files. So then the afternoon before your part, it's usually at noontime because they try to take it to a lunchtime so the docs can come in and eat lunch and be at the session and not miss surgery or miss patients in their offices. So you make sure you take that list to the surveyor. You've got 40 names on it. And I can tell you, as many times as I ask people to keep track of these people, the poor MSP would come to me on that day and they'd have one name. And I'd be like, what have we been doing all week? So then I'm trying to come up with people. So you give them those 40 names, they'll pull out the 10. These are the 10 we're going to look at during that review So that's the best way. Just ask the quality manager, hey, can I meet with the doc? Or if it's a nurse, it's usually a doc. If it's a bigger hospital, anything that's a 3-day survey is most likely going to have a doc on it. So can I meet with the person doing the medical staff session? I just need 15 minutes to go through this list, figure out who they're going to ask for tomorrow, so I have the files ready.
Yeah.
They'll make sure they make the time for you.
So the surveys are going to ask for specific files. Again, I already kind of spoke to this. They're going to ask for all licensed independent practitioners, including APPs. Make sure that your list, whatever you've come up with from following their tracers or getting a list from your quality folks, make sure that it does include all those areas. Keep track of those names, pull those files, know who's working in the areas. I think I kind of got ahead of myself in that last slide and spoke to all of this. So I'm going to just jump to our question, which is for organizations that have changed to from a 2-year to a 3-year reappointment timeframe, what might a surveyor be looking for when reviewing these credentialing files? And the surveyor says,
okay, well, first off, your surveyor is going to make sure that the changes to the term of reappointment do not contradict your state law. They will ask for your state law to know that, and actually, at least when I was a surveyor, they started doing this, and I think they still do it. And that is, they have all these state laws on their laptops that they can pull up. So they can pull up and see, did your state allow you to change from 2 years to 3 years? And then you want to make sure that your bylaws and policies and everything else got updated to reflect that. And the last thing they will make sure is that no provider exceeded the 2-year time frame while you were moving to a 3-year time frame, because that's a huge job, as all of you know. And you want to make sure that no one fell through the cracks and exceeded the time frame they were currently reappointed through.
and that would be an easy thing to see happen. Oh, we've got Dr. Smith who's up for reappointment in February, and he expires on February 28th, but we expect the board on March 3rd to approve a 3-year reappointment cycle. Not going to work. He's exceeded his time frame. So just be very cognizant of not moving anybody sooner than they should. Now, if the board approves it on March 3rd and you don't have somebody who's expiring until March 31st, you're okay. As long as you're prepared to make a notation and note that that reappointment period was extended for that year. But I want to put a personal disclaimer out there. As I'm working with hospitals and MSPs across the country, I'm seeing people start to move to this 3-year cycle, who I will say, well, what's your OPPE, PPE, FPPE peer review process? How has that been? Oh, well, we got a finding about it at our last survey. Those are the hospitals who should not be considering moving to a 3-year until they have really strong PPE processes. The reason we're moving to a 3-year cycle, and Joint Commission has graciously agreed to do it, is because our PPE should be bumped up. It should be hefty. It should be able to identify trends in the practices before problems occur, before we can even see that a patient has had a bad outcome. So if you do not believe that you have a value-based PPE peer review program that can catch things before they happen, you still need to stay at that 2-year reappointment period until you get your PPE bumped up. So I'm going to talk about surveying the file. This document is gold to you MSPs. We're going to send it out to you in a PDF after the presentation today. We're going to send it. It's going to be found in that survey activity guide that Lori shared at the beginning of our presentation. And this is the document that I put into place with my own team. And I would assign so many files at each and every month. Okay, I want Sally to review 2 files this month, give me a critical care and an ED provider. And I just want you to review their file as if the surveyor has just asked for the file. This document will be so beneficial to you. But here's some of the things I want you to focus on as you're doing those regular file audits. High risk specialties, non-physicians, those APRN, psychologists. Surveyors are getting smarter and smarter and smarter, not that they weren't already at the beginning, but they know the files that we struggle with. And those are some of those psychologists, those APRNs who aren't being tagged in that medical record. And so we're not getting good data out of our quality system. And what does our OPPE look like for those providers? Moonlighters, those who aren't at the hospital all the time, they want to pull those moonlighters to see what you're doing. Is their credentialing different? Is their OPPE up to par? Unusual procedures. I will have surveyors straight up say, I want to see somebody who has robotics and fluoroscopy privileges, because they know there's certain criteria that should be present if a provider has those privileges. Telemedicine practitioners, we're really going to talk about that in a minute, but they want to know what your credentialing process is. If you have teleradiology or teleneuro groups, and how are you credentialing them, and is it different than your standard process? And then newly granted privileges, why do they want to see that? They want to look at your FPPE. So just be aware of some of those really specific areas and use this tool that we're going to send out to you guys. It will highlight every single thing that a surveyor wants. And let me just share with you, if you walk into your surveyor session and you've already pulled the 10 files that they want to see, and you've filled out this document for them already, God bless you. That's what they will say to you. God bless you. This document is already filled out. You've put the dates in. Don't just give me a check mark that that current license is there, but put in the date that you actually verified it. You're doing their work for them, and you will give them a sense of security that this is a well-run medical staff services department. So we got another question. When reviewing the credentialing files, do surveyors prefer the documents to be compiled in a PDF and presented on a screen, or do they prefer seeing the MSP navigate the credentialing database? And the surveyor says,
well, that depends. If you can easily navigate through the database, that's fine. At least when I was a surveyor, and I think it's still true, that no Joint Commission surveyor will require you to print anything out. I don't believe they're supposed to require you to print anything out. But the worst thing in the world is when you're trying to present files and you don't have all the information, or you can't navigate, or the room internet doesn't work, or pick your thing that could go wrong. And if you're not practicing doing all this navigating, that will definitely get you in trouble, because if you spend an hour on one file, that will be a problem. Yep. They don't have a lot of time. So remember, they only have a set amount of time to get through their processes.
Yep, absolutely. So again, just going back to what I just said about files, I will tell you, when you're having your team audit those files, this last bullet on this screen, and both bullets on the screen, keep a list. I used to keep a list. If I assigned Sally to audit some files for me, and each of my team members audited different files, and I was auditing files, I kept a list, and with the date that it was audited. All right, Dr. McCourt's file was audited in June of 2023, and she's had no changes in her privileges. She's not gone through another reappointment. And then my surveyor comes in and they ask me for a family medicine practitioner. I got one on my list because here's a specialty. Here's the last date it was audited. I have a list, and I go through those special areas where we talked about some of the things they'll ask for, those telemedicine providers, those robotics procedures. Make sure you're focusing on those areas when you're auditing your files, and keep a current list of what's been audited and when it was audited. This is really valuable. So you have a list to turn to when that surveyor says, pull me a neurosurgeon. You have a list of everyone you've got clean files on, and practice.
Now I know how you do that.
So again, OPPE, FPPE, really a pointed area that surveyors continue to look at. We're going to really cover this a little bit more in our questions, so I'll kind of get past this slide, but some of the examples of the OPPE data are shown here. If your process is not data-based, if you're still doing references to accomplish your OPPE, that's really probably going to have a finding. You really need to be able to show that you can show the volumes, show the outcomes. You're looking at outcomes. You have specialty specific metrics that are in place to guide your tracking and trending of the provider's competency. Here's just some of the standard standouts that we see of different findings, not necessarily related to the credentialing and privileging, but medical records lacking that documentation from an in-person evaluation of restraint and seclusion. Joint Commission is always going to have a heavy focus on restraints and seclusions. That is a very high-risk area for patients. So they're always looking at that. Verbal orders authenticated within 24 hours. Let me tell you, as a MSP, if you end up getting a finding related to verbal orders authenticated within 24 hours, you are in for 6 months to a year of showing compliance with this, which will be arduous and difficult. And we
just remember, I just want to throw this in, Sarah.
Yeah.
That 24-hour window, that is set by your organization, okay? That is not set by Joint Commission anymore. The Joint Commission that was rigid. But then CMS said, okay, we'll let them set their own thing, because honestly, CMS says with current electronics, there should be no verbal orders.
Right.
So,
right.
and believe me, when I've gone down a rabbit hole on survey and I've said, I want to see this what's this percentage of how much verbal orders do you have? And they're like, oh, well, and then all of a sudden the rabbit hole opens and they're all falling into it, because they're like saying, oh, geez, because as soon as the surveyor starts seeing all these verbal orders on tracers, then they start asking, I want to see your data. I want to see your data
digging
on
into
verbal orders.
The cultural rabbit hole, because
we
struggled with this, right? But I do want to add, it's not just the facility in every case. Many states dictate that hour window for signing off on verbal orders. I know Joint Commission really eased up on it, but every
Joint Commission will survey to your state law.
Right.
Always. So
so you can see some of those other metrics, and of course, triggers defining when an OPPE becomes a focused FPPE. They want to see that you know what that threshold is. If I've got a provider who 3 OPPE cycles in a row has had a higher mortality rate than others in their specialty, surveyors want to hear that you have a process that automatically triggers that FPPE. What are your department specialty level thresholds that would move someone from an OPPE to an FPPE? And then trends in focus, again, I'll let you guys, we're going to send these slides out. I want to make sure we can get to all the questions we can, but these are some of the areas that are really highly focused on. The different committees, disaster privileges coming out of the pandemic. We really have a strong focus on what did you do during that time? How did you go back and verify those licenses if you granted emergency privileges? CME, I used to always get asked about CME, and here in the state of Illinois, we would say they attest to it and the state tracks it. Just know that process. Don't be caught sitting there with a surveyor saying, well, we don't ask for CMEs, but I'm not sure how we prove that to you that we know that they had them. I knew. We do an attestation and the state tracks them, and they assigned fines in my states. Out-of-date privilege criteria. Do you have criteria that doesn't even clinically make sense anymore because you haven't looked at your privilege forms in 20 years? Surveyors will key in on that really quickly. Physicians practicing in areas where they don't have those specific privileges. That's a huge one. And that's one that's so frustrating for MSPs because, well, I never gave that doctor privileges to go over to that clinic and be doing those needle biopsies. And that surveyor is going to say, well, I just saw him do one. And you're going to go, why didn't somebody let me know? Those are things I want you to be thinking about. And then department specific orientation information. This would nail me all the time. I'd have a surveyor say, great, I see your initial appointment orientation, but where's the documentation that the OR director or the medical director of surgery actually went through that orientation and orientated that provider to the surgical area? Be thinking about that. How can you prove it? Can you just have a document added to your orientation? Those kinds of things are things that surveyors will definitely ask you about. So, Ms. Sharon?
Great. Thank you both so much. So much great information. So you asked, we listened. Like I said, this webinar was designed for you. So we're going to go ahead and jump into a bunch of the questions that were submitted prior to today's webinar. And then I know we've got questions in the chat as well. We will do our best to get to all of those Q&As where we can. So we're going to go ahead and just get started on these, but let's get to these questions.
Awesome. So for the past 7 years, this was a question that came in from one of our audience members, and I love it. Thank you to whoever submitted this. This is wonderful. For the past 7 years, we have used MD-Stat to assist with the development of OPPE report cards. During this time, we have had 2 triennial surveys and 2 joint commission surveys. Each time the surveyor looked at the report card, felt that they were satisfactory, moved on. Last month, a surveyor looked at one of the report cards, felt it wasn't up to snuff, and gave the medical staff office a deficiency in 08, 01, 03, EP2, citing the OPPE metrics were quantitative with no privilege specific quality metrics. Why in the previous surgeries was this not cited? No other surveyor mentioned they had a problem here. This is confusing and frustrating for me. I've been here. I feel your frustration. I know what you're feeling because you are never sure what they will focus on from one survey to the next. One time you're fine, the next you're circling the drain. Love this question. We all can relate to this as MSPs. So what does our surveyor say?
Okay, well, number one, every year in January, the surveyors have an annual meeting. And it's a different week now than it used to be. I used to always say, if you never had to worry about being surveyed the first week of January because the surveyors were all in Chicago for their annual meeting. But I think they vary the week now, so we can't say that anymore. But they are trained to interpret standards differently during different survey cycles. So just because they did it even a year ago during your total joint survey does not mean that the next year they will be doing it the same way. And OPPE has been around a long time. So their expectations are being very, very, I guess I could say that they are expecting more out of you with regard to OPP, not out of you, but out of your organization. So you have to be up to date in that latest interpretation of the standard. Look at the FAQs. That FAQ on OPPE is so very detailed. It will tell you everything you need to know about OPPE. But if you do not have privilege-specific standards in this stage of the game, I can tell you, you are going to have an RFI, because they will score that almost universally. And remember, they're trying to be more consistent. So they're using those tools. So you need to use the tools so that you're one step ahead during your survey. However, if by some chance you're part of a big system survey and one hospital gets scored and one hospital does not, I would take that to the quality department and ask them if they can put a clarification in. They try to clarify as much as they can during the survey, and you can have a call with the Joint Commission during the survey. Many of you don't know that, but you can. So if it comes to it, though, the quality director can say, wait a minute, we weren't scored here, we were scored here. We have the exact same process, it's standardized. And the likelihood is the Joint Commission will clarify that out. But you better have all your ducks in a row if you're going to ask for that.
Absolutely.
Okay, next one.
So any tips on reappointment steps for tele by proxy? Surveyor says.
So number one, Joint Commission doesn't really use that term, tele by proxy, but they do have very specific mechanisms for credentialing telemedicine providers. These are illustrated in MS 13010101. You all know about originating sites and distant sites, which took me the longest time to make sure I didn't get those two confused. But nonetheless, let the surveyor know what method you are using to credential and privilege your telemedicine providers. And the last bullet is telemedicine services are often contracted. Work with your quality folks so that when that contract is written, work with the docs involved. And if, say, it's a radiology contract, work with the director of radiology and get it written in that the distant site's going to provide to the originating site for credentialing, or they're going to provide the org-specific, provider-specific OPPE. They're gathering all this data on OPPE. All your contracted services are. That's how they market to your leadership to hire them. So consequently, they have to give them data that they provide good care. So make sure that you ask them to be providing that OPPE data to you so that you can have it in your file and can speak to it at the time of a survey. Next.
So each time Joint Commission, they change what they are looking for with the FPPE1. Some of what they are requesting is not possible for a small hospital. Do you have a best practice measures or forms, et cetera, that is sure to keep us in compliance with FPPE1? I think this question, the next one, are kind of going to be in this same area, but let's go over it. What does the surveyor say?
Real quick, FPPE1, I assume you're meaning initial FPPE for a new provider. So, or a new privilege for a current provider, but they're not asking for what you should be looking for. They expect your medical staff, not you, your medical staff, to determine what measures they're going to track on those individuals. Now, it would make sense to, if you've got privilege specific metrics for your robotics docs, that you track in OPPE. Well, you might as well just track the same thing for the new person for FPPE. I mean, why reinvent the wheel? So they expect you to come up with, not you, but the docs, to come up with what you're going to track for FPPE initially or initial privileging. If the provider is actively practicing, then honestly, FPPE should be resolved in the first 3 months. So if a surveyor talks to a hospitalist, the hospitalist says, oh, I've been here since August and it's November. And oh, how much do you work? Oh, I'm full-time. And then they pull their file and they ask for their FPPE and you have nothing. That's going to be a problem, because from August till November, you should have something for a full-time practicing hospitalist.
Now, I'm going to holler out at my MSPs on the call, because I know what you guys are all thinking. I just don't have the capacity. I don't have the FTEs. I don't have the resources in my office to pull that data, get that to committees, and get that done in time. We're going to talk about that. Our last slide is going to talk about how that's okay. The surveyor comes in and they says, it's been 3 months. Why haven't you gotten this done? I'm going to give you a finding. I don't want you to be afraid of that finding. And we're going to talk about it in the last slide. And I'm sorry, I'm rushing us through. I know people want to drop at the top, but I want to get as far as we can.
Yeah, we have so much information.
I know we do.
And again, this is a reference back to the FAQs. And the next slide, I believe, is the same type of question. It's about OPP and FPPE. Again, reference back to those FAQs on OPP and FPPE. It will give you exactly what you should be utilizing. And I will say that all of you MSPs, if you belong to your state groups or you're part of a system, rely on those system folks to help you. You aren't in this alone. And that's really key. Know what you're buying. If you're buying software, I had North, and they gave me data that I'd only been there 2 days. I knew it wasn't valid. And when I asked them, they said, oh, well, we don't know what happened. They told us this would give us all the information we needed. And they went back to the software person. Here they had only purchased the inpatient module. They hadn't purchased the outpatient module. Well, you can imagine for an anesthesiologist, how many cases are done outpatient versus inpatient. It was hundreds different. So know what you're looking at. Make sure the data makes sense. And if it doesn't, take it back to quality, take it back to your department chairs, say, what are we going to do with this? And then take it back to the folks you're paying for that software and say, this data doesn't make sense. You should have an IT person in the room whenever you're creating new metrics for OPP or FPP, because they're not clinical. They don't know what to ask for as far as keywords if they're trying to pull things out of an electronic medical record. So make sure you have somebody at the table that can say, oh, okay, give me some more keywords and let me see if I can find this and find any data at all in the electronic record.
Absolutely.
Okay.
I love this one. What can we do to make the surveyor's job easier or more efficient? Surveyor says,
okay, ensure you have all the documentation for the files chosen. Now, I know you folks are the greatest at credentialing, privileging. You probably have dragged the docs in for OPP and FPPE, and we're going to talk a little bit about that. You've dragged them in. You said, no, you have to be there so you can talk about this. And I'm not the only person in the room talking about this. But what about, you require ACLS for your moderate sedation privileges. And so the surveyor says, well, let me see the most recent ACLS. Oh, well, that's with the education department. Well, hey, you're required for a privilege. You better have that documentation available. So you either have to have the education person in the room with the documentation, you have to have the list of all the people that were at ACLS and the dates, whatever it's going to be, but it has to be there. If they're going to spend a lot of time looking for it, that'll be a problem. Remember, a lot of your docs are employed. If your employees are required to have immunizations and somehow your docs have not managed to get the administration to exempt them from that, if you're required to do it, then so are they, unless you can prove otherwise. But schedule your medical staff leaders during that session. So say to the surveyor, we're going to schedule from 12 to 12:15 the surgeons, And then that way the chair of surgery can be in the room to discuss OPP and FPP. That way your docs are not giving up an hour of their time or an hour and a half. They can be there and they don't have to listen to the neurologist drone on about their colleagues when it's the surgeons really want to go back to the OR. So you want to make sure that you can schedule it. And it's okay to say to the surveyor, this is how we've set it up. In fact, they will be very happy because it makes sense to schedule people so that they know they don't have to be there for the whole time.
How much do you all love that tip? I wish I had thought of this before Lori said it to me. Dr. McCourt, sorry, we've become very personal. Sorry, I keep calling you Lori. But she said, you know, if I've given a list of 10 files I want to see, divide them up by specialty, schedule your department chair of surgery to be in there. We'll do the surgeon files first. And when that OPPE scorecard comes up, that department chair signed off on, he can speak to that OPPE scorecard. It takes all that pressure off of the MSP to explain your OPPE processes. Now, you should have prepped your chair, but how much better would a survey go with this? I loved this tip. And I learned so much from this in addition to you guys. So I hope you guys are learning something too. And then practice. Yes. Make sure everyone knows their role. That plays into that. If you're going to schedule your department chair, make sure that they know you're scheduled from 12 to 12:15. We will present the credentials, but when it comes to that FPPE scorecard, OPPE scorecard, you're going to have to speak to what you signed off on. So do you want to go over it with me real quick before? Have them ready and prepped for that moment. So here's our last slide with some takeaways. I want to stress this. Keep calm. Don't fear the finding. In the first decade of my career, I mean, I was just a physical bomb of a mess when the surveys came in because I knew we tried hard, but I also knew we didn't always meet our timelines on PPE. We didn't always get people off of FPPE within that first 90 days. And I would just be a ball of nerves. And we all know, you're an MSP on this call, you know what I'm talking about. You struggle with what we're required to do versus what we have the resources to do. Let the finding be your friend. If you're being asked for FPPE to be completed in 90 days, figure out how to present the metrics on why you're not able to do that with the staff that you have. And I'm happy to talk to people. I have all kinds of tools. I've shared tools that have gotten people FTEs, but think of those findings as your stamp of validation that I've been saying to my CMO. I've been saying to my CEO that I don't have the resources and staff to get these things done. Let that finding happen and let that be your proof. I need resources who are helping me track OPPE. I need to hire a clinical person into my department to help me pull that data because quality doesn't have enough staff to be helping me pull data. And I think I can bring a nurse in who could help me work with the docs to get through the OPPE data. This is your opportunity to advocate for yourself and what you need in your organization. In the case of serious findings, you're going to work with those quality folks. Talked a little bit about those verbal orders. Man, when I had to start tracking all those verbal orders, I mean, we had my whole team calling docs every single day saying the state says you got to do this with 24 hours. So either stop doing verbal orders, log in and put that order in yourself, or you're going to be getting calls from us and you're not going to be able to do surgery the next day. We had to put policies in place and we had to tell Joint Commission, what are our actions to resolve this within 30 days? This is a huge undertaking to resolve things, but it's much easier to say, we didn't have the resources to get this done. We've added a resource to our team and in providing that information. But no, it's going to be a team effort when you communicate back to the Joint Commission on how you're resolving those issues. Work the problem to resolve the issue to be in compliance, not just to fix the issue. Us making calls for those 24-hour verbal order sign-offs, that was really tough, but we really needed to work on the bigger issue of not allowing verbal orders any longer. So think about not just how you're going to get through the finding, but how you're going to change the culture to really match what the intention of that Joint Commission or that state regulation is. We shouldn't be doing verbal orders anymore. Everyone has Epic on their phone. Everyone has Cerner on their phone. They can go in and enter those orders. The reason that's in place is because mistakes get made when a doctor gives an order to a nurse and then the nurse enters it into the system. It's in place to protect our patients. And then do a deeper dive that just goes into what's the intention of that standard and what's it in place to protect. Because like we talked about at the beginning, that CEO said, I don't want to have to call and say my dad's a VIP. I want every patient to have that same level of care. And that's the intention of all of these standards, CMS, Joint Commission, DNV. They want to know that every patient who walks through the door is going to be treated like that CEO's father. So really think about the intention of the standard that you've gotten a finding in and where it impacts your patients and what can be changed in your culture to make it better. That the Joint Commission is going to appreciate that response. Hey, we have put these in place to address 24-hour verbal orders. They'd much rather you say, we're cracking down and not going to allow verbal orders. Each month, we're going to measure how many providers are putting in verbal orders, and we're going to have a performance improvement initiative to drive down those verbal orders. That's the kind of response they're looking for. So with that, I know we've rushed through the end. We have so many questions in the Q&A. I'm going to go back and review them, and hopefully we can give you materials that we send out, the deck and the supplemental materials that answer some of those questions. But also, you can always reach out to me. I'm happy to be there to answer questions for you. Thank you. Thank you. Thank you.
I just have to throw something in. I was so thrilled to be back, but you'll love to hear that you are my FPPE. So I would, I've been gone 10 months, so I would much appreciate all of your feedback, any of your feedback, and how we can continue to offer worthwhile webinars to all of you. And thank you for what you do every day.
Thank you both so much.
McCourt.
So much great information today. Again, just as a follow-up, your CE credits will come out to you as your certificate will come directly from the Hardenbergh group and the follow-up email that comes. And again, thank you so much for joining us. Thank you so much for the great questions. We so appreciate each and every single one of you. Have a great day.